Look, welcome Oh, thank you. Yeah. Welcome everyone to our Australian Indonesian Glaucoma Symposium. And it's great to have everyone here on a Tuesday night in December. The weather's warming up in Australia, and it's always warm in Indonesia. I hope you've all had some dinner. We have exciting presentation today. We have got Harry Honan from Royal Perth Hospital in Perth presenting a case of a slightly complex glaucoma. And then we've also got Artie presenting a case on managing lens-induced glaucoma. Well, Artie's going to give us the theory, I should say. So without any further ado, Harry, would you like to share screen and show us your case?
Very much, Prof. I'll just start sharing again. Okay. Hi, everyone. Thanks very much for having me. It's a pleasure to be here. So my name's Harry. I work at Royal Perth Hospital as a registrar. And today I'm presenting a case which is well known to Prof. Morgan. So I'll just get started. So this is an 80-year-old Indonesian woman who's initially referred to Royal Perth back in 2017 for a right Zen and MMC. And at that point, she had already had quite severe end-stage glaucoma. And we recently saw her 6 weeks ago, but I'll just provide a bit of background. So initially when she had the right Zen in 2017, she was seen for ongoing monitoring, had sort of fluctuating disease, so worsening disease it was quite difficult to manage her to her target intraocular pressures, despite quite aggressive management. She required a right Zen redo in 2019, and then we proceeded with a left Zen in 2020. But despite that, and despite being on maximal drops, she had bleb needling in 2020, 2021, and again in 2022. But when we saw her 6 weeks ago, so these are her current medications. She's just on Travatan and Azaga in the left eye, and the right eye is reasonably well managed at the moment. Just to give you an idea of kind of the challenge in maintaining her target intraocular pressures, this is just mapping her pressures from 2017 to 2023. So you can see a lot of spikes and a lot of difficulty keeping that consistency. And she's required multiple procedures, multiple episodes of needling. At times she's been on systemic treatment with Diamox, and then she's required maximal drops as well. So when we saw her a few weeks back, this is her examination. So best corrected visual acuity on the right is 618, and on the left is 612 plus 3. And then her pressure on the right was 8, so quite good. But on the left had crept back up to 21. And she's sort of an interesting case in that she has very, very tight lids, so it's quite difficult to examine her eye and also to get a good view of the bleb, especially on the left. And that made it difficult to consider doing further needling to that eye. Just to note previously, she's got very shallow angles as well, and she's previously had cataract surgery. And I'll just show you some images of her fundus shortly, but she's got severely cut discs, a very end-stage glaucoma. That's just an image of the left eye there, so you can see the Zen stent. And it's difficult to appreciate, but when we're trying to get images of the bleb, very, very tight lids, difficult to get a good view. And there, I'm not sure if those fundus images come up well. They're a bit dark, but you can see how severely cupped the discs are, and you can appreciate the notching, especially on the left. And in terms of investigations, that time an OCT was done, which you can see here shows severe thinning of the RNFL, and a visual fields 10-2 was done, which shows severely constricted fields with an island left, particularly bad on the left, and ganglion cell loss. So her case was quite difficult in the sense that the left Zen is moving towards failure, so the pressure's creeping back up, but there's not, I guess some of the things that we could discuss today is where to next in her case. So it's going to be quite difficult to do further needling. She's got a very, very small island of vision left, and so doing a further procedure is particularly risky. And so that might be worth discussing. And something else that was interesting to notice when you look back in her notes is that quite often routine investigations would be done, and for example, a 24-2 visual fields would be ordered, despite her having quite advanced disease even from the beginning when she saw us in 2017. And OCTs were pretty much done at every appointment, and it raised the question of how much is that adding every time that we're doing an OCT at this stage of the disease. So Prof knows her case very well, and might be able to help guide the discussion, but I wonder if anyone has any thoughts about this case, or any questions about it, or what they think might be an option next in management, and also what choice of metrics they might use if they were monitoring a case like hers for progression, and is it appropriate to continue to do, or what you think it's appropriate to continue to do in terms of fields and OCTs.
Yep, thanks very much, Harry. The reason I asked Harry to present this case is really to do with monitoring and judgment of progression. So Harry, could you go back to the slide showing the OCT nerve fibre layer? So there you can see it's a flat line. We've reached the bottom of the range, and we would never pick progression in either eye based on OCT, because there's really almost no neural tissue left to measure. So it's a point really for our registrars that it is a waste of time doing OCTs in this sort of patient to monitor their glaucoma. Now, obviously, if they have a macular problem or some other problem, then you might be wanting to do an OCT. But for glaucoma, when you've lost so much of your nerve tissue, the machine cannot, there's no signal left to measure. So you've reached rock bottom, basically, and you'll never detect progression. You're much better off doing frequent visual field tests. And in her situation, that's really a 10-2 field, because the 24-2, well, the field loss is right down close to the center of fixation. And in fact, in the left eye, even a 10-2 is probably not going to be too helpful, because if you lose much more field in that left eye significantly, then she's blind. Well, she's legally blind now because of the field restriction, but that visual acuity of 6/18 will almost certainly go. So, but the right eye, the better eye, there's really no point doing more OCT scans, but rather the resources of the clinic should be directed to doing visual field tests and 10-2 fields at least twice a year, maybe 3 times a year on the right eye. The question of what we should do for the left eye with a pressure of 21 is complicated. So I ended up speaking to this lady about trabeculectomy and also Molteno tube surgery. So trabeculectomy has a high chance of failure when a Zen stent has failed early on, because physiologically they're quite similar. They're both drainage operations, draining into the subconjunctival space. And a trabeculectomy's got a moderately high chance of snuff out or sudden jarring of the left optic nerve. Molteno tube or Werner GDD may be the safest option surgically, but it still also carries a very significant risk. So in this situation, I've spoken at some length with the patient and told them about the options. And then I really leave it up to the patient. So she's not keen on surgery or more surgery because of the risk. And I think that's a very reasonable decision. So it may take a year or two for that left visual field to gradually disappear or go. But there's a moderately high chance that any surgery we do would almost instantly destroy that remnant of visual field. So that risk is probably 10 or maybe even 20%. So I think when you put those figures to the patient, then whatever decision they make is really the best decision. So that's been my approach, but I think we've probably got a couple of minutes. If anyone would like to ask any questions about this case, particularly about what they would suggest doing for the left eye, or...
Can I ask?
Yeah, Artie.
Okay, yes. Do you think it is helpful to like doing the micropulse? So yeah, transscleral cyclophotocoagulation. I mean, it's like it claimed to be not affecting the visual acuity, right? Is that possible option? And also the second thing is, how about what do you think about a low dose oral medication for a long term, right?
Yeah, so they're both very good questions. So Diamox, I think we've offered her Diamox, and I'm not sure if she's accepted that or not. But
she's
that's
previously been on a low dose of Diamox for some time, and then I think her renal function was affected slightly by it, so it was a bit difficult to continue on it.
But it's a very good, thanks, Harry. That's a very good question, Artie. The micropulse laser, we don't have a micropulse laser in Perth. We've only got the standard cyclodiode. And at least in my experience, there's a fairly high chance of significant uveitis or transient inflammation with pressure reduction. But I think the risks are probably not dissimilar to trabeculectomy with the standard cyclodiode. I don't really know about micropulse. There might be slightly better, but I suspect there's still significant risks there. But you're probably right. It probably is safer than a Molteno tube or Werner GDD. But the flip side is that the pressure fluctuations often are worse after any sort of cyclodestructive procedure, because you're effectively knocking off aqueous production, but not changing outflow facility at all. So the pressure fluctuations may still remain. The mean pressure may come down, but the pressure fluctuation may still remain. So it's very hard to know whether you would be altering the long-term outcome for this patient, because I doubt whether you'd get really good pressure stability with any sort of cyclodiode. But the short answer is we don't have it in Perth, so we can't offer it. And maybe it is a reasonable option. Yeah. Any other questions before we move on to Artie's talk? We can come back to this at the end if people would like to ask more questions. Artie, would you like to, perhaps if you stop sharing, Harry, thank you for the presentation. That was very good. And it was nice that you stuck to the case and the case details and signs. So that was great. Artie, thank you. We're looking forward to your talk on lens-induced glaucoma. Thank you.
Okay, I'll share my screen. Is it visible, Prof?
Yes, that's excellent. Thank you.
Okay. Yeah, so thank you, Prof. Good evening, everyone. Thank you for my seniors here giving this opportunity to me. Tonight, I would like to deliver my talks about the lens-induced glaucoma. In the next 30 minutes, I will try to cover several basic learning from about the lens-induced glaucoma, including the definition, classification, as well as the pathogenesis, clinical presentation, differential diagnosis, and management of each type of lens-induced glaucoma. So by the definition, the lens-induced glaucoma is a secondary glaucoma in which the crystalline lens is involved in the mechanism of intraocular pressure increase. So lens-induced glaucoma can be classified into two categories by the involved mechanism or the pathogenesis, which are due to the aqueous flow obstruction and glaucoma due to the lens protein. In the first category, there is an anatomical obstruction of aqueous flow from the posterior to the anterior chamber. This class include the phacomorphic glaucoma and also ectopia lentis. And the second category is the lens protein related glaucoma, means that there is a leakage of the lens protein across an intact or a ruptured lens capsule. These category include the phacolytic glaucoma, lens particle glaucoma, and also a phacoantigenic glaucoma. And as mentioned before, one among 5 forms of lens-induced glaucoma is the phacomorphic glaucoma. I think it is an angle closure glaucoma caused by an intumescent or a swollen cataract in an eye which originally is not predisposed to angle closure. I think it's the most common type of lens-induced glaucoma that we can find in clinic. And in this form of glaucoma, the apposition between the iris and lens disrupts the flow of aqueous humor, causing the accumulation of the aqueous in the posterior chamber, pushing the iris root forward and adhere to the trabecular meshwork, thus leads to the secondary angle closure glaucoma. We can see in these two schematic pictures here how the bulgy lens anatomically block the aqueous flow. And so the clinical presentations of phacomorphic glaucoma is often very similar to the acute primary angle closure. Patients often come with a markedly high IOP, red and painful eye with a microcystic corneal edema and halo due to the abrupt rise of IOP, fixed dilated pupil, and sometimes the inflammatory cells and flare in the anterior chamber may be observed. Anterior chamber should be shallow, and if it is possible to have a good gonioscopic visualization, the angle is found closed, and we may observe the intumescent or thick lens pushing the iris forward. And if the pupil is not dilated and the cornea is quite clear enough, volcano-like appearance of the anterior surface of the iris, or called the Mount Fuji sign or Fujiyama sign, may present, confirming the significant lens factor of the glaucoma. So this is one of our patients in RCM Kirana with phacomorphic glaucoma. He came with acute eye redness, pain, and severely blurred vision, and the IOP at the presentation was 54. noticed the eye redness, the pupil was dilated, the cornea was hazy, and there was an immature cataract, and the AC was very shallow. Looking at all of these signs, we could also think about the acute attack of the primary angle closure glaucoma. But however, when we look to the fellow eye, the anterior chamber was deeper. The gonioscopy exam on this fellow eye also proved an open angle, but pardon me for not having the gonioscopy image here. But this showed that in phacomorphic glaucoma, the fellow eye is not predisposed to an angle closure originally. So as previously mentioned, the differential diagnosis of phacomorphic glaucoma is an acute primary angle closure. And the important distinction between those two diagnoses is the condition of the fellow eye. In the acute primary angle closure, both eyes are predisposed to angle closure. These two studies here conducted by Mogimi showed more detailed differences of ocular biometric parameter of the phacomorphic glaucoma and primary angle closure eyes. This study on the left showed that the eyes with phacomorphic glaucoma had a greater axial length, greater lens fold, but with a shallower anterior chamber depth than the acute primary angle closure eyes. I think this suggests that in phacomorphic eyes, the eye itself is actually not a small or short eye, but due to the bigger lens, the chamber become shallow. And the study on the right analyzed the biometric parameters of the fellow eyes and compared between the fellow eyes of the phacomorphic glaucoma patient and the fellow eyes of the primary angle closure patients. And it shows that the fellow eyes of a primary angle closure had shallower anterior chamber depth, greater lens fold, as well as more anteriorly displaced lens than the fellow eyes of the phacomorphic patients. This confirms the fact that in primary angle closure, both eyes anatomically prone for angle closure. An initial treatment of the phacomorphic glaucoma is to lower the IOP with IOP lowering medications. However, the use of pilocarpine is remain controversial due to the pilocarpine effects in increasing axial length thickness and anterior lens movement, resulting in anterior chamber becoming more shallow and thus worsening the condition. Another important aspect of the treatment is controlling the inflammation with the topical steroids. And in any cases of phacomorphic glaucoma, especially those with the presence of iris bombae indicating a pupil block, LPI remains a strong components of early management. And some references also suggest that argon laser peripheral iridoplasty or ALPI can help in lowering the IOP by pulling the peripheral iris from the trabecular meshwork. After controlling the IOP and establishing the intraocular inflammation, we should proceed to the lens extraction as the definitive treatment, which erases the major causative factor of the disease. In some cases, however, of filtration procedures and cataract extraction are necessary for a long-term IOP control, or it can be an option for some chronic cases. Performing trabeculectomy only is doable without cataract surgery, but poses an increased risk of a flat anterior chamber and aqueous misdirection in this kind of case. Regarding the option of performing ALPI in phacomorphic angle closure, there is a study by Prof. Clement Tam that showed favorable outcomes of ALPI as initial treatment. With these laser parameter settings here, all of the patient showed downward trends of IOP from the mean IOP about 56 before the ALPI down to approximately 13 in 24 hours. cataract extraction was then performed in 2 to 4 days in all of the patients. And looking at this study, I personally think that the ALPI is worth to perform. And additionally, this procedure is also relatively quite easy to perform, even simpler than performing the laser iridotomy. Cataract extraction in phacomorphic eyes may not be straightforward. It can be quite challenging. We should expect some difficulties, including the shallow anterior chamber and high pressure lead to the iris prolapsing from incision. High intralens pressure and increased convexity of the anterior capsule also leads to difficulties in performing the CCC and causing the unwanted capsule tear. And the shallow AC may also bring the phaco tip closer to the corneal endothelium. And also there is a possible zonal weakness in this kind of case. Some recommended techniques to alleviate the problem includes improving capsule visualization with trypan blue, do the initial decompression of the lens with the 26 gauge needle, use the dispersive viscoelastic to protect the cornea, as well as a cohesive visco near the capsule to negate the posterior pressure. And the stop and chop technique is said to be more preferable rather than divide and conquer to minimize the trauma to the zonule and corneal endothelium. And sometimes when the AC is very shallow, partial pars plana vitrectomy is needed and cataract extraction is performed once the anterior chamber had sufficient space. I think these are the suggested technique to increase the safety of the surgery, but I'm sure every surgeon here may have their preferred tricks to overcome the expected difficulties. Regarding the option of combined phacotrap in phacomorphic cases, there is a cohort study which compared the result between the phaco alone versus the combined phacotrap. And despite the risk of more inflammation, IOP spikes, and impaired longevity of bleb in combined procedure, this study suggests that both procedures had similar IOP control at 6 months. However, the cataract surgery alone resulted in a better visual recovery. We move to the next form of the lens-induced glaucoma, which is the ectopia lentis. The ectopia lentis defined as a dislocation or displacement of the natural crystalline lens. It includes both two terms, the luxated lens and subluxated lens. The luxated lens means the lens is completely outside the hyaloid fossa. Here, the hyaloid fossa is the depression on the anterior surface of the vitreous body in which lens should be located, and luxated lens can be completely in the anterior chamber, just as our patients here in these two middle pictures where the lens is completely in the AC. Or luxated lens also can happen to the vitreous, or the lens is lying on the surface of the retina. And other form is subluxated lens, in which the lens is partially displaced, so some part of the lens is still within the hyaloid fossa or the lens space, just as seen is in our patient's picture here on the right. Etiology of the ectopia lentis may relate to some systemic disorders such as Marfan's, Well-Marchesani syndromes, and other disorders with biochemical defects that results in zonal dehiscence, or ectopia lentis may also caused by the previous trauma. The mechanism of IOP raise in this condition is due to pupillary block, whether the lens itself comes forward and blocking the aqueous flow, or the vitreous phase that comes forward to the pupil. Other possible mechanism is due to the complication of the previous trauma itself, if any, or the complicated by inflammation. The clinical presentation sometimes initiated by increasing degree of myopia due to the progressive disruption of the zonules that allows the lens to a more spherical shape, and monocular diplopia may also present if the lens is shifted within the pupillary axis. Difficulties in accommodation and near vision can be happen due to the loss of zonular support, hyperopic shift if the lens dislocate completely from the from the pupillary axis, just as seen as in aphakic patient. And ectopia lentis may also cause an acute angle closure symptoms if there is a pupillary block. Phacodenesis and iridodenesis may be seen through the slit lamp examination, and there is a difference of anterior chamber depth between the two eyes. Management of the ectopia lentis may differ, depends on the dislocation degree and the symptoms. When the subluxation is partial within the pupillary space, no visual impairment found, and no pupillary block glaucoma, we can observe the patient without surgical intervention. When there is a partial subluxation within the pupillary space, no visual impairment, but pupillary block glaucoma is present, laser iridotomy is recommended. If there is a total anterior lens dislocation or hypermeter cataract, if inflammation is present or the IOP cannot be well controlled, the lens removal or lens extraction is suggested. If the lens has been displaced totally to the vitreous body or retinal surface, lensectomy with vitrectomy should be done. The next form of the lens-induced glaucoma is the phacolytic glaucoma. This type of glaucoma happens due to leakage of the lenticular material, which is called the high molecular weight proteins, from a hypermeter or Morgagnian cataract through an intact lens capsule. This picture on the left showed the schematic mechanism of what happened in the phacolytic glaucoma, and the right picture here showed an example of our Morgagnian cataract patient. This showed more detail of what happened in phacolytic glaucoma. So with age and cataract progression, the amount of high molecular weight protein in the lens increases. In immature cataract, these proteins are found only in the nucleus of the lens, but with the cataract maturation and protein accumulation, increasing amounts of the HMW proteins are found in the liquid cortex of the lens. And along with the maturation of the lens capsule is also microscopically changes. So eventually, the lens capsule allows the release of the proteins into the aqueous humor. Then the HMW proteins obstruct the aqueous outflow by blocking the trabecular meshworks, thus causing the IOP rays. In addition, the presence of the lens proteins in the anterior chamber also leads to the inflammation and a macrophage response. And it was previously believed that the accumulation of the large macrophages was the primary cause of the IOP rays, but however, it has been determined now that the release of lens protein alone are sufficient to cause the obstruction and the IOP rays in phacolytic glaucoma. Clinical presentation of the phacolytic glaucoma include the presence of hypermeter or Morgagnian cataract, acute pain and eye redness, acute onset of decreased visual acuity, with a previous history of gradual visual loss over months or years before. The high IOP can be found, the cornea with edema, and the angle is open if visualized by gonioscopy. There is a significant flare, large cells, and soft white patches on the lens capsules or whitish materials in the anterior chamber. I think this is our patients here with the phacolytic glaucoma from Kirana. We can see the eye is red, and there's a soft white materials in the anterior chambers leaking from the lens capsule that macroscopically we cannot see where the unintact part. And there's a heavy flare here, and the chamber is deep in this patient. The differential diagnosis of the phacolytic glaucoma can include the acute primary angle closure, phacoantigenic glaucoma that we will talk about it later, and the lens particle glaucoma. The management of the phacolytic glaucoma includes the administration of the topical cycloplegia and steroids and anti-glaucoma medications to control the IOP, and the lens extraction as the definitive treatment. In rare instance where the IOP is uncontrolled, sometimes urgent cataract with or without the vitreoretinal surgery may be required. The next form is the lens particle glaucoma. In contrast to the phacolytic glaucoma, this form of lens-induced glaucoma is associated with a grossly disrupted capsule and the presence of the obvious fragments of lens materials in the anterior chamber. It may occur after cataract surgery, trauma to the lens, or even after an NDAC posterior capsulotomy. The IOP increase is due to the obstruction of the aqueous outflow by the lens particle itself. The macrophage as a part of inflammatory response may present, but it is assumed not too significant in the glaucoma formation in this kind of case. Some of the clinical presentations may be similar to the other form of lens-induced glaucoma, such as the eye redness and the corneal edema. And the lens particle glaucoma can cause an altered visual acuity or sometimes not. There should be lens material observable in the angle, commonly in form of fluffy cortical materials with or without a lens nucleus fragment. Moderate eye inflammatory reaction and synechia may present, and these pictures on the right here is an example of an eye with an iris claw IOL with some big cortical materials at the angle and also at the pupillary axis. This is also our patient with the IOP raised 1 day after phacoemulsification, and there's a corneal edema, and apparently we observe some fluffy cortical materials at the inferior angle of the eye. So some differential diagnosis may include the phacoantigenic glaucoma, phacolytic glaucoma, or an uveitic conditions sometimes. The management of lens particle glaucoma include the anti-inflammation therapy with steroids, anti-glaucoma medication, and sometimes, but not always, a surgical removal of the lens materials if the lens materials is large or severe glaucoma is present. And the last form of the lens-induced glaucoma is the phacoantigenic glaucoma. This is, I think, the rarest types of the lens-induced glaucoma. I think I haven't found any phacoantigenic glaucoma in previous 1 or 2 years, so I'm sorry for not showing its clinical pictures from our hospital. So the mechanism of this type of glaucoma is that originally, naturally, the lens protein, which is an immune privilege, are sequestered in the lens capsule. After an eye surgery or trauma, there can be a release of this sensitizing lens protein. This induces an Arthus type immune complex reaction, which is a subacute type 3 hypersensitivity reaction mediated by IgG and the complement system against this sensitizing lens protein. Product of this immune complex reaction blocks the trabecular meshwork and aqueous outflow, thus causing the IOP to increase. And the clinical presentation of this phacoantigenic glaucoma include the conjunctival injection, corneal edema, intense anterior chamber reaction, posterior synechia, and we can find a mutton fat keratic precipitates, just like a granulomatous uveitic, and sometimes it can cause an anterior phytritis. It is typically occurs 1 to 1 days to 2 weeks after surgery or the trauma. The definitive diagnosis requires the presence of the PMN leukocytes in the aqueous or feature specimen, but I think this exam might not be always available. The differential diagnosis may include the chronic uveitis. As we know, there's a presence of posterior synechia as well as mutton fat KP, so we can put the chronic uveitis as the differential diagnosis, and other differential diagnosis include the phacolytic and lens particle glaucoma. The management is not too differ from the lens particle glaucoma, which include the administration of steroids, cycloplegic anti-glaucoma medication, and also the surgical removal of the lens material itself. So, and finally, to summarize, the lens-induced glaucoma is a secondary glaucoma in which the crystalline lens is involved. The pathophysiology include the aqueous outflow obstruction or a lens protein related. And in most cases, the mainstay or the definitive treatment is removal of the lens or the lens materials, preferably after the inflammation and the IOP is quite under control. And the challenges may exist in the lens removal of this kind of case. Appropriate methods, optimal preparations, and attention to details of the surgery are mostly required. So thank you very much for your attention. Thank you, Prof. Morgan.
Thank you, Artie. Thanks very much. That was a great presentation, and you've really covered very comprehensively lens-induced glaucoma. Now, have we got some questions? And I'm going to look, I think we have. We've got some chat questions here.
I think there's a question about the previous case, Prof. Morgan.
Yes, sorry, there's a question from Cockwinnie. Thank you for the interesting case. I have a question. For the right eye, you did a Zen in 2017 and then a Zen redo in 2019. For the left eye, you did a Zen in 2020 and then needling every year after. What is the reason for different action on both eyes? So with the right eye, the redo of the Zen was because there was a leak in the conjunctiva. So we had to seal the leak with pulling down, excising the hole in the thin region and pulling down the conjunctiva that was on the right eye. So that a bit like if you have a trabeculectomy, thin bleb with a leak, so a similar treatment there. And also the pressure was generally pretty well controlled. We didn't really need to do any 5FU injections. Whereas the left eye, unfortunately, the bleb tended to fibrose and the bleb tended to be smaller. And so it just so happened that we were doing 5-fluorouracil needling about every year to try and get that left Zen bleb going. It wasn't really deliberate planning to make it an annual injection. It was just the way it worked out. I suppose one question you might have is, why didn't we do a trabeculectomy in that left eye? And the main reason was that the left eye had a very bad visual field, and we thought that a Zen stent is probably safer in the sense that you don't tend to get such profound hypotony in the first few days. And that is what really puts the eye at risk of snuff out. And that was the main complication that we were fearful of. So that's why we did the Zen stent. The problem with the Zen stent is that you don't tend to get as low pressure as you do with the trabeculectomy. So there's a trade-off, but we thought that the safety margin was a little bit better with a Zen stent. So I hope I've answered that question.
Prof.
Next
Morgan,
question.
can I ask about the Zen? Is it an option to do like put more than one Zen?
Yes, we don't, not at the same time, but what I've done is if the Zen stent works well for a few years and then it starts to fail, I've sometimes put a second Zen stent in, and often that's worked reasonably well. Also, occasionally the first Zen stent is not in a very good position. So sometimes the end is only just through the episclera and not into clear subconjunctival space. And that often fails early and you really can't resuscitate the Zen. So then I'll put a second Zen stent in. So, and there are I have seen a Zen stent where I think the Zen was actually put into the supraciliary space or suprachoroidal space. There's no sign of it in the subconjunctival space. So I've done a second Zen then. So it depends if the Zen is in a good position and it's not blocked by particle matters, and if it's not fibrosed, then it should work well. If it gets blocked by there's a curious situation where some patients produce a white material, and it's not those with pseudoexfoliation. It can be other patients as well, which can block a Zen. And because the Zen's so small, only 45 microns, it's prone to blockage. Or if patient gets more fibrosis, then I won't do another Zen because it's highly likely it will fail. And also, if a Zen fails rapidly due to fibrosis, it usually means that the aqueous humor is not tolerated very well in the subconjunctival space. And that often means that a trabeculectomy will fail quite quickly as well. So often in that circumstance, I'll go straight for a glaucoma drainage device. So sorry, that's a very long answer to your question, Artie. Sorry about that. We have a question to you, Dr. Mead, Artie. I'm Nabila. Can vitreous tap be an option to lower intraocular pressure before doing cataract extraction? And I'm assuming this is in phacomorphic glaucoma.
Yeah, I think maybe it's like a posterior sclerostomy, something like that, Prof. Yes, I think it can be an option, but practically, most of the time I didn't get an effective result from that. Sometimes we can have like put some fluid and maybe the block or the accumulated aqueous behind the iris can be pulled out, but I don't think it's quite easy to have that. And if we have it like we try to put some vitreous, I think in most of our patients, the vitreous is still quite thick, so we cannot have the vitreous that easily. And in my experience, maybe even though it will, sometimes it will lower the IOP a bit, but I'm not sure that it will stay low during the rest of the surgery. So later I'm not doing that anymore, but maybe Prof. Morgan or Dr. Firna have different experience about this.
Yeah, so I think what you're saying is can be a temporary fix, but not a permanent one, and that I would agree with that entirely. I think occasionally, if the anterior chamber is really shallow and it's also, as you were saying, Artie, the cataract surgery can be quite difficult in these patients. So sometimes you do the initial keratotomy of the first wound, and the anterior chamber goes flat. It's almost as if the lens is really wanting to be pushed forwards. and then you put in your viscoelastic to try and deepen the anterior chamber, but even that gets pushed out of the wound. So in that circumstance, I think you really have to do a vitreous tap or even a posterior vitrectomy, just pars plana vitrectomy, to remove some of the vitreous and create space so that the anterior chamber can be formed, and then do your phaco. But that's, I think you stated that in your talk, Artie, and yeah, I would agree entirely with that. We have another question from Michael Hartono. Thank you for the presentation, Dr. Mita. I'm Michael from University of Indonesia. If our patient already had the phacomorphic glaucoma, is there a risk of developing phacomorphic glaucoma in the other eye, in the fellow eye? And when should we operate on the fellow eye?
Okay. Yes, I think it's possible that the fellow eye later have the same condition, but I think it's not like the primary angle closure that the other eye is really predisposed to the same condition. So for the other eye, I think the indication of surgery is I mean, I don't suggest like an early lens extraction, something like that, but I think we can still observe and see whether with the maturation of the lens, the angle becoming shallow or not. I think that's still the indication. So I don't think I will hurry to do the lens extraction based on the other eye condition. That's my opinion, Dr. Prof. Morgan.
Okay. I think it's an interesting question. I think I see quite a bit of phacomorphic glaucoma. We'd probably call it ciliary block in patients with primary angle closure. So I think there is a relationship to primary angle closure. And as you know, primary angle closure is usually bilateral. So there probably is slightly increased risk. But I agree with you, Artie, unless there is actual angle closure, then I'm not necessarily, well, unless there's a cataract, but I'm not going to do a clear lens extraction unless there is actual angle closure. I may do prophylactic iridotomy in the other eye, depending upon the state of the angle. But I don't do a clear lensectomy. I was going to just say, Artie, I think you emphasized all of the factors really well. And there's one factor that you emphasized, which I agree with entirely, and that is weakness of the zonules. So some of these patients don't have really short eyes, but they may have pseudoexfoliation or other reasons for weak zonules. And that allows the lens to shift forwards. And that worsens or amplifies ciliary block or phacomorphic glaucoma. So when you see eyes, especially if it's sort of unilateral phacomorphic glaucoma, there's not really been a story of primary angle closure. Really think about the zonules. Now, our classic clinical test is to look for phacodenesis. So you're asking the patients to look left or right, back to center, or you wobble the slit lamp desk. The problem in this circumstance is that you will almost never see phacodenesis because the lens is being pushed up against the iris, and the iris is holding the lens stable. So even if the zonules are weak, you will never see phacodenesis. So you won't know until you actually start operating. And then you'll know because when you put the viscoelastic in the eye, if the pressure's not too high, all of a sudden the anterior chamber will massively deepen up and the lens will sort of float right back. And in that circumstance, you know that you've got a tricky operation ahead of you. Or sometimes the lens will be problematic and the ciliary block will persist and it'll squirt the viscoelastic out. But it does make the surgery much more challenging. Werner, you might like to comment as well, because I know you get some very challenging cataract operations. I've seen you handle them very well in the setting of phacomorphic or lens problematic glaucoma. But maybe you like to comment as well.
Thank you, Prof. I think yes, that we face with phacomorphic glaucoma in certain cases, especially I know that patient with prior zonal dehiscence, Prof, like if the patient has like zonal dehiscence, so we may have patient with you know, some kind of pupillary glaucoma due to the lens, and then because of the zonal dehiscence, so then the lens position tend to move forward because of the weakness of the zonal. So then in this case, I know that in doing the surgery in patient with the shallow anterior chamber, we have to prepare with those conditions. So not only we face with the I mean the thickness of the lens, but also we have to be prepared when we face with the zonal dehiscence. We know that sometimes the lens will be moving when we did the capsulorhexis, or then even when we did the phaco emulsification, the you know, the BSS will flow even into the back of the eye, into the back of the lens. So then we will have the very high IOP during the surgery. So I have one case that when I did the surgery, then I have to do the like a posterior sclerectomy, or maybe like vitreous step, but actually not the vitreous that I was taking, but actually the BSS that actually flow to the back. And then when I take it, it is quite easy to move to take out the BSS from the posterior of the lens using the needle, the syringe 1 cc at that time. When I'm able to take the BSS, then the IOP is lower again. So yes, it is very challenging. So I think that when we do the surgery of the patient with the shallow chamber, then we should prepare with many things. The first thing that it is very, very important, I think that we have to manage the IOP first. So don't do the surgery when the IOP is still high. So even I usually do the or give the patient with a hyperosmotic agent, Prof, to shrinkage the vitreous a bit. So then we will be sure that the patient have a lower IOP during the surgery. And then also we have to be prepared with like maybe iris hook or something like iris retractor or capsule tension ring to be able to maintain the capsule, so it will be stabilized during the surgery. So we have to be prepared with that. So it is not that easy to have patient with cataract and then the shallow chamber, whether it is phacomorphic or whether it is angle closure or whether it is patient with pseudoexfoliation glaucoma, that we know that this patient has a weakness of the zonal. So we have to be prepared. That's maybe things that I learned from the from doing the surgery with the angle closure and also with shallow chamber patient with cataract.
Werner, thank you. That's a great description. And I totally agree that often the first sign is when you start doing the capsulorhexis and the lens, the lens is starting to move around under your needle, and you get those traction lines in the capsule, and your heart really sinks. It's you know you're in for trouble. Thank you, Werner. We have another question from Paramita. Thank you for the presentation. My name is Fitri from University of Indonesia. In lens-induced glaucoma, if the IOP cannot be reduced with topical or oral medications prior to lens extraction, is there any procedure that we can do to lower the IOP? Artie, would you like to answer this? I think you've covered it, but you might like to reiterate what you would do.
Yes, I think in cases where we have give the topical medication and oral medication, and also the inflammation has been tried to be controlled, but the IOP is still high, one of the option is to giving the hyperosmotic agent, maybe near the surgery. Glycerin, I think, works well in most of my patients. Mannitol, sometimes yes, sometimes not. I don't know why. And also, I think one thing that I will do if I really want to take out the lens, but the IOP is high, is I'm doing it under the general anesthesia. I think that's quite helpful. That's it, I think, from me, Dr. Prof. Morgan.
Yeah, thank you, Mita. And the other thing which you did mention before was doing a vitreous tap. I think that's the other thing that you can do, or a posterior vitrectomy to create space. Werner, have you got any tricks up your sleeve that you do in this situation?
Yes, Prof. The one that I've mentioned previously, that I usually try to give hyperosmotic agent, Prof.
Yeah.
Whether it is a glycerin or whether it is mannitol to shrinkage the vitreous, then we make sure that the IOP will be lower during the surgery. But then if I can't lower it, although I have given the hyperosmotic agent, usually I will do it under general anesthesia. When we do it in general anesthesia, we know that the IOP will be lower, and then also the patient will be, we don't have to be worried about the patient. One thing that actually make it worse if the patient is not calm. So the patient feel anxiety, or you know that angle closer glaucoma patient tend to have type A personality, so they tend to worry too much. I know most of my patient has that characters. Most of my patient have that characters, so that it is. I think if we know that this surgery will be difficult, or the surgery will have like a quite fluctuated IOP, or then we can't control the IOP prior to surgery, although we have a hyperosmotic agent, I will do it under general anesthesia. So it will make it safer. And then if we want to perform the vitreous tap, it will be not too painful for the patient. And then most cases, if I did that under general anesthesia, it is very, very safe. And usually the patient, and I mean, I might be able to have all the surgery safely until the end. Usually because with the general anesthesia, the IOPs usually most of the cases will be lower. Even it could achieve like 20, even below it. So it really helped me too.
Yes,
Thank you.
That sounds good. I think I've only had to do a posterior tap or vitrectomy twice in 20 years. So like you say, it's obviously you've given them mannitol, all the drugs, and under a general anesthetic. So it's very rare that you have to do a vitreal tap. So thank you, Werner.
I tend to avoid doing the vitrectomy, Prof. Posterior vitrectomy. I tend to not to do that. But if it is like no other ways, then I have to. But usually I try to as much as possible.
I try and avoid it too. Yeah.
Yeah.
Do everything else first. Yeah. I don't. Yeah. We've got two other questions. This is not sure who this is from, but can lens-induced glaucoma be caused in pseudophakic eyes? If so, is there any surgical technique that has less risk of causing lens-induced glaucoma? So the question Artie, I think, if you would like to answer it. So can lens-induced glaucoma occur in pseudophakic eyes?
Yes, Prof. I think in some types of lens-induced glaucoma, such as the lens particle glaucoma and also the phacoantigenic glaucoma, it's still possible in the pseudophakic eyes because of the history of trauma and history of surgery can be the initiator of that event. So I think to prevent it, while doing the phaco surgery, I think we have to manage to clean all of the materials, including the cortex and all the fragments, so we can minimize the risk of that kind of reaction or blocking of the trabecular meshwork.
Great. There's another situation as well, where years after the cataract surgery has been done, if the patient forms Sommering's ring, so soft lens material growing into the capsule and re-expanding the capsule. So rarely it'll expand the capsule out to the ciliary body and cause a ciliary block. But that's probably the subject of a whole nother talk, and maybe I'll give a talk next year on angle closure and I can include that. But it's fairly rare, but you probably will see it. It's in elderly patients who've had cataract surgery 10 or 20 years or more prior, and who've got a tendency to a smallish eye. We're getting more questions. This is from Kiara. Thank you for the presentation. My name's Kiara from University of Indonesia. In ectopia lentis, should all the lenses be extracted, or can we do some observation beforehand? Artie, I think we hardly see much ectopia lentis. You are the experts, actually. So tell us what you would do.
Yeah, I think in some types of ectopia lentis, some degree of ectopia lentis, we can do observation and give a conservative treatment in case of if the dislocation itself it's still in the pupillary axis and the patient didn't have a visual acuity reduction, and also there's no pupillary block, we can still observe. If there's a pupillary block and the visual acuity is still good and the lens dislocated is still in the pupillary axis, we can just do the laser iridotomy without extracting the lens. But otherwise, if the lens is totally displaced or the IOP cannot be controlled, or the inflammation occur, we have to extract the lens, I think, Prof. So there's still some degree or some symptoms that we can still observe, or maybe just doing a laser.
Yeah, thank you. And then last question. Thank you, Dr. Mita, for your presentation. I'm Marcia from University of Indonesia. In cases of lens-induced glaucoma, is it possible for the condition to progress even after lens extraction? What factors would you contribute to such progression? I think you've answered it partly, but you might like to expand on this, Artie.
Yes, I think if because it is like a secondary glaucoma, if it's only a secondary glaucoma, I think if we aim to remove the major causative factors, it's likely to not progress anymore, unlike the POAG or types that maybe the optic nerve is already prone. So if we manage it well and the definitive treatment has been done and the IOP can be lowered, or in cases that is no permanent pass during the previous condition, I think usually the prognosis is quite good. But in some cases where there's if it's a chronic cases, like what I've said before, sometimes the filtering surgery or other glaucoma surgery is still needed to maintain the condition of the patient, even though the lens has been extracted.
Yeah, thank you. I think you also previously you mentioned if there's retained soft lens matter or remnants in the capsule, and it's phaco anaphylactic or phacoimmunogenic, then that can, the glaucoma, lens-induced glaucoma can persist. And also, if it's purely particulate, it can persist if not all the lens is removed. It also happens rarely in ciliary block. If the, and again, we probably need to go into the theory here, but ciliary block is due to two reasons, largely due to a large lens abutting the ciliary processes, causing blockage there, and your typical cataract extraction will cure that. But there's another cause of ciliary block, and that's when the anterior hyaloid is thickened. And this happens in patients with angle closure, and cataract surgery won't fix that. So if the dominant cause is thickened anterior hyaloid, so the aqueous is held up in the vitreous, then those patients will still get a closed angle post-cataract surgery, and the intraocular lens will tend to be pushed forwards. They're quite rare. I think my experience only about 2% of so-called phacomorphic, or maybe 5% of phacomorphic, will have that. And if that's the case, then you need to do what's called a large peripheral iridectomy with a zonulohyaloidectomy and a posterior vitrectomy. So you probably, Werner, have you seen that happen? I've had a few, but they tend to be elderly patients. Well, not always. Actually, no, I've had a couple of younger patients in their 40s and 50s. But sorry, Werner, have you seen that happen?
In my cases, yeah. For patient with the usually patient with lens-induced glaucoma due to phacolytic prof, it's already like there is already like the one that Mita has mentioned about synechiae in the angle because of the uveitic, inflammatory reaction, so that it disturbing the flow after even we already had cataract extraction. Then sometimes I have to put the glaucoma drainage device on that case, but it is not that, it is not quite often. So yeah, it is so most of the secondary glaucoma due to the lens, usually we are able to maintain the IOP after we take out the problems. The other thing is a patient with a lens particle glaucoma usually, Prof. So I have cases like that, several cases. Usually patient post-trauma, and then we have to do the, and then the patient has cataract surgery, then it is not that clear, still lens remnant because there is already capsule tearing in the posterior part. So there is some remnant of the lens in the patient eye, so that it caused the inflammatory reaction, and then the IOP become high again. So after also, although we have do the aspiration of the lens material, it still have high IOP. Then I have to put GDD usually. Yeah, I have some case like that, but not that much. Not that much.
Yeah. We've gone way over time, which tells us we've had lots of questions. Artie, tells us your talk was clearly very good. Thank you, because you've had lots of interest and lots of questions. And we've also put you on the spot. You've answered lots of difficult questions, so very well done. And Harry, thank you for your case presentation. It's really great to see everyone. Werner, is this our last talk of the
Yes.
year? I think it is.
I think this is our last, Prof. Our last. We will start next January, Prof. January 2024, I think.
Yeah. Okay. Sounds good. We'll have to plan some really exciting topics.
Yes,
And
for the next. If you want to have like another consultant, Prof, maybe from like retina or
yes.
Yeah, immunology. If you want to, is it possible? Or?
Yes, I will ask, Werner. Thank you. That's a great idea. And of course, I'm looking forward to seeing lots of you at the APAO in Bali in February. And that will be fun.
Yes.
And so
Prof, don't forget your royalty, Prof.
Sorry?
Your royalty.
Oh, golly. Oh, gee. We'll have to talk about that later, but I'm happy for it to be used for research at the university, but we can talk about it. Maybe we'll talk about that in Bali.
Yes,
Thanks everyone. And
we have to take a photo, Prof.
Oh yes, we have to take a photo. Sorry, I'll take my glasses off.
Dr. Miki, please help us to take a photo.
Okay, Dr. Mita. I would like to invite everyone to open your camera, please, so that we could begin and conduct our photo session shortly. Okay, I will wait another 10 seconds. After that, we'll begin the photo session. Okay, everyone, give us your best smile. I'll start taking pictures. 1, 2, 3. Next page. 1, 2, 3. Third page. 1, 2, 3. And last one. 1, 2, 3. Thank you, everyone. Back to you, Dr. Mita.
Thank you, Miki.
Thank you, Miki. Thank you, Mita. Very nice presentation.
Thank you. Thank you. Nice to see you all.
Nice to see you, Prof. See you, Prof.
Thank you.